Thank you very much for this wonderful presentation, and seems the genetic therapy is on the door. If there is anybody with a question, please have a seat, so then we will run. We will pass the microphone. I have one question for Dr. Tanaka. Dr. Tanaka, the question is do you think we should integrate more the imaging on the time of the ablation? You know, there are these new cath lab that are coming up with MRI guide catheter or stuff, but they never take off because, I would like to have your opinion about that. Thank you, Andre.
Of course, that all of you can do ablation without seeing images, probably. That's how it works. But I think that you should integrate CT and MRI into the cath lab, and then you involve a lot of electrophysiologists, young people who work in other hospitals. That's what I think.
Yeah, I think we can definitely do better ablations if we see something. So I think there is a future into it.
Yeah, and also a question about the late gadolinium enhancement, which can be found if you read the guidelines in hypertrophic cardiomyopathy, for example, in 65% of patients. So the burden becomes important in the risk stratification. Which role does it play? Because it seems to be more than just present or not present. Are we going to take decisions on ICDs? It would mean, for example, for hypertrophic cardiomyopathy, a lot of patients we have to implant on that basis. So it's impossible to answer, but I would just raise the question that it puzzles us as clinicians. We have the risk scores; they are often not included. Look at the LMNA risk score; it's also not included. This septal. So I would just like to know your opinion on this.
Yeah, as we saw on the derivate ICM studies, that elbow ejection fraction of 35% should not be the real cut-off, like a reimbursement of ICD implantation. The main things on that article, that the mass of LGE is really going to contributing for the ventricular arrhythmia, and they should have ICD even if the ejection fraction is more than 35%. That's always Pedro always saying, like 10 years ago. So it should be the mass of LGE should be integrated to your clinical.
Yeah, we should base on that. Okay.
Maybe just
I think the major problem with hypertrophic cardiomyopathy is and that's why LG is not used to calculate the risk of the patient, is that the threshold is very high to get a very high risk. In other words, you need more than 20% of LG, for example, to really change the prognostic in terms of arrhythmia of the patient. And this score this threshold is so high that, in fact, all the patients that get to the 20% of mass with the LGE intake are already identified by the conventional score. So in this patient, I don't think that LGE really help for the decision. Although, of course, if you have no LGE in a patient that is in the gray zone, this is pretty reassuring. So I would turn it the other way. And there is another problem with your question, I think, is that there is a difference between the threshold for an ICD and the risk of the patient. This is a bit complex, but this is something very important to understand. It doesn't mean that you have a high risk, that you necessarily will need the ICD. The ICD of the benefit of the ICD is not calculated just on the raw score or the raw risk of a patient. And this make, of course, the decision very difficult for us, because there is confounding factors, there is confounding risk, there is a lot of other parameters to take into account.
You're alluding to older patients, more comorbidities, that the ICD,
That's one of the example.
renal function and stuff. Yeah, it's.
But I think if I can just add something, and I think I totally agree, we should work with much more integration of all this. And if we talk about VT, for example, I think it's essential to do what Andreas does, pacing from both sides. We need more functional data to add on top of the imaging, deep analysis during VT induction protocol. We need, I think, high-density maps with extracellularly to understand whether the channels are functional or non-functional channels that could contribute to arrhythmia. I think there is a lot of things we can learn from this integrated approach.
So I also have a question to Kaoru, because by following on Eve's footsteps, that so for me, I also have a problem with yes LG, no LG. That is what we have been also doing in the EP lab, that we say it's if the voltage is at a certain limit, the patient had low voltage or doesn't have low voltage on, and we all know that fibrosis doesn't work like that. So it's a continuum. And I'm asking you about this concept, that are you planning to change it? And here comes again the burden, of course, that if it's the LG is more than 20%, that can be predictive, because that's probably more fibrosis. And the second, what I wanted to ask you, that can you tell me, do you see any difference between dense scar, patchy scar, what we call dense scar? Probably you have a different algorithm, nomenclature for this. But so it's obvious that not every kind of scar is arrhythmogenic. I think we should dive into the characteristic of the scar, trying to say, can you tell me something about that, which scar is arrhythmogenic or not? And I'm very interested in that T1 ECV. Is that something that we can use in the UZ Brussels?
From the last question, T1 mapping, we are only doing like a septum and a 4-chamber view. We don't do the 3D T1 mapping. If you want to see like a 3D VT circuit, probably you have to go 3D T1 mapping, but which is probably very time consuming, but it will come for a rapid T1 3D mapping. I don't know yet. That paper was a very small number of 18 patients, but T1 mapping we do. And then delayed enhancement signal intensity, we have software to see how much is the signal intensity differences. So if you'd like to see the differences of a pixel intensity, that we can see it. And then the last question is,
For the different types of scars, this replacement scar, interstitial fibrosis, this kind of thing. Every LG is the same? So that you don't see any differences between LGs. Every type of LG is the same.
No, Andrea, talk on the micro because we have to.
Oh, she forgot the question. So I remind it. Okay. Yeah, you don't want to answer that. I know Pedro has a question.
Well, yeah, Kaoru, the time that we have been working together, I think that we all realize that there is an increasing problem with MRI use in athletes. In the sense that, with the screening that they get for a new club to participate in competition, now MRI is more and more frequently done, and then they see something. And then comes the question, is that an artifact? Is that real? People are excluded from competition, sports, and so forth. What do you think? What can we do? I mean, first of all, do you agree about the artifact problem? And second, can we, by integrating maybe the different technologies, get better idea whether this is an artifact or whether this is something real?
so especially the presence of LGE is going to change the life of the person, that if you say that there is LGE, so I think that the more we have to be very careful, just not to say, but to repeat in few times. If you see something, you have to focus not only on short axis, but on the long axis, and then you have to repeat after a few minutes, and then you have some changes of the phases that you have to change, and then if you do everything, then if you are sure that you have fibrosis, you can conclude. But it is true that it will change the people's life. So just to say, there's a fibrosis in one sequence is a very dangerous thing, and we have to really pay attention to it.
Yeah, I have a question about genetics. So a common enough scenario that is very frustrating to the clinician is that you have a patient with, say, a survivor of sudden death or whose first-degree relative just died, and you do genetic testing and you get some VUSs that you don't know what to make of. And the question is, do you think that's just a matter of incomplete knowledge of these VUSs, or is there more to be known about how different VUSs may interact with one another? Or there's maybe just variations in gene expression that may not be detected when you just do genome analysis, and perhaps we should be doing biopsies and doing RNA sequencing in biopsies. So is there any way to refine what we're getting now?
Yes, at the moment, what they are pulling out are the VUS that are what we call in class 3+, which means the ones that already have either they are in a codon where we know that in that codon on the other letters there has been a pathogenic variance. So those are considered that this is in the same codon and therefore perhaps it's affecting it in the same way. So those are actively followed up. So that's one type. The others that are followed up is that if it has an effect on the rest of the protein, which like truncating or something like that, when it gets moved up. So and then that we try and solve some of them by doing segregation analysis, which means we look at the family members. But that's quite difficult to move it from category E if we don't get people far away from second or third degree and having the condition. The other way is to test the parents if they are alive, because if it's de novo, it automatically gets pushed up. It means that both parents are not carrying that variant. It gets pushed up in a category as well. So it goes to a category 4 because he's got something new and it's having an effect immediately. So there are criteria that are being used in saying we try and get the 3s out of the 3, because 3 is a terrible category to be in. And it's the biggest category. It's about 50% of all analyses have a VUS.
So you are telling us that we should send all our VUSs to you for families for segregation analysis. Is that what you are telling us? Because we usually... You are not getting them. You are getting them, okay. Because we just had this discussion, I think last week we had, or this week even, a patient with an intramural scar for a VT ablation, and you described the lamin VUS mutation, I don't remember which one, but that's, as you are saying, we are standing there in a situation when, obviously then the whole family needs to be screened for this VUS, because this 10 to 90% is for a clinician is very difficult. Probably of pathogenicity. Somebody had a question there or not?
Tommy, maybe it's a very stupid question, but actually, do you perform paternity studies when you do the genetic testing? Do you systematically look that the father is the father, the mother is the mother, etc.? Yeah.
When we test the parents, we automatically will see whether it's not the father or not the mother. And in that case, I have 2 or 3 a year. And then I call back whoever is the one that we don't think is a biological parent. And I say that we have a problem with our test. We're going to have to repeat it. Do you want it repeated or not? Is there anything that can explain that? Have we swapped the samples around? And all of them have given the reason. Yes, I had I've had cases where the wife says, yes, I didn't know which of the 2 men was going to be the father, so I chose this one and married him, and it's the other one. So I know that. Or I've had couples that have split for 6 months because they decided they're not going to live together, and they each got a new partner. And the woman falls pregnant, and then the couple get back together, and they know about it. The husband and wife know that this child belongs to somebody, has got a different biological father, and but the children don't know it. And then they say, we don't want it to be told to that one child because after that they had another 2 children with the same couple. So in the middle of this 5 kids, there's one that's got a different father. But we call them back in to just discuss it, and usually they tell us that they're aware of it in most cases.
Okay.
No. That's enormous. That's enormous. No.
Okay, look, I will close with mater semper certa. So,
When they are young, the percentage is very low, but when they are older, for the next children, it increases, that the father is not the father.
it's okay, but that's, I don't think increase the risk of VT. As far you're not... No, thank you very much. I'm sorry I'm coming up here because the sand is over. You know, the hourglass, like in ancient Romans, that you put on the table when you start your speech. The sand is over, but the good news that the lunch is ready. So we can move on the next room where we did the breakfast, and you can have a lunch. Please enjoy your lunch, but be back on time because I'm very happy, and I thank all speakers because we are perfectly on time in a very busy program. Enjoy lunch, please. Thank you.